We'll get started. Yes.
Jesus.
I don't think anybody joined the Zoom. All right. Yeah, I just using just using it to record.
I'll stay on it in case someone else.
That works. All right, so this works. Okay, sweet. So for y'all that I haven't met, my name is McKenna Box, one of the MS4s, and
Oh, you're gonna say my name is Ty. I'm the MS4.
yeah, we'll have one or two other of us come later whenever we get to use the fun stuff there in the back. We only have 5 girls, so we'll have to figure something out, but we'll get it worked out. So basically kind of the gist of what we're talking about today is what medical school doesn't teach you about orthopedics, which is basically everything. But what we're focusing on today is the principles of fracture fixation. This is especially important to those of you that are MS3s and MS2s as you're going into your selectives next year as 3s and going into your sub-Is. This is basically a lot of stuff that I didn't learn until I was a 3 or a 4, and wish somebody had told me about it earlier. And it's something that people just assume you know on your sub-Is, but then no one ever teaches you it. So that is the goal of today. Yeah, no disclosures. So some of the learning goals for today. First, we want to understand some of the forces that cause fractures, describe the basics of primary and secondary bone healing. We want to understand the anatomy and functions of a screw, and then understand the biomechanics of plate fixation and understand the different functions of a plate. So a little bit of introduction. We will cover a lot of physics principles today. Physics is the foundation of orthopedics, but it's orthopedics, so it's fun. So the first question, kind of get things kicked off, is what causes fractures? So before we get into that, kind of need to go over some of the biomechanics of bone and some of the properties of it. So some of the material properties, bone has 2 main ones. It has, I always terribly say this, anisotropy, and it's viscoelastic. So with anisotropy, that's basically where the stiffness of the bone is depends on the loading direction. So bone, you know, your bones, you're walking on them, they're straight up and down. That's where it can withstand the most amount of strain. But whenever it has a transverse force put upon it, that's where it's weakest. So that's where a lot of fractures happen, is due to loading that occurs on the bone that overcomes its stiffness and leads to it breaking. Also, bone is viscoelastic, which I like to think of this kind of as water. So the stiffness of bone depends on the rate of loading. So, you know, if you're doing just slap water, it's going to be really stiff, but you can, going really slow, you can put your hand into it. So bone's kind of the same way. If you load it really fast, it can withstand a lot of stress and get really stiff, but you can do a lot of slow loading and the bone stays pretty soft. This is especially important in the metaphysis and the epiphysis, where a lot of cancellous bone is. So going into the different forces that can cause fractures, you have 4 main ones. You have a transverse fracture, an oblique fracture, and a butterfly fragment is kind of a mix of a transverse and oblique fracture, then a spiral fracture. And each one of these have different forces that cause them to occur. So with transverse fractures, these usually are due to bone failing in tension. So here you see force going this way, causing the bone break in a transverse pattern, versus an oblique usually has some sort of compression component or a bending and a torsion component. So here you can see this pilon fracture, or it's basically a fracture of your distal tibia there at the ankle joint. That happens a lot due to axial loading from falling from a height. And then when you have compression and bending, you can end up with this oblique fracture, and then a further kind of mix between a spiral and an oblique fracture whenever you have bending and torsion. Then with the butterfly fragment, so what a butterfly fragment is, let me get a highlighter, is basically, think about it, is any piece of bone that isn't connected to the proximal and distal portion. So this portion right here, if you removed it, it's able to be removed. But at the same time, the proximal and distal portion can still touch each other in this segment right here. And then next you have a spiral fracture, which is due to torsion, so a lot of twisting motions. And basically this fracture pattern, the fracture spirals up and around. So you can end up with this a lot in the distal tibia with a spiral fracture. Again, you can have a fracture here, then that fracture can spiral down and include the ankle joint. So now that we covered that, how do bones heal? So I'm going to start with secondary bone healing, and then we'll get to primary bone healing next. So secondary bone healing is the ways that our bodies have healed fractures since the start of time. It's composed of 4 stages. First, whenever the fracture begins in the first weeks, you have this hematoma stage, where the ruptured blood vessels from the fracture fill the area with blood and forms a hematoma. This hematoma, and the weeks after, is then what we call formed into a soft callus, which is made of a lot of cartilage and fills this area, and then new blood vessels start to form through this area. From this point, the cartilage is then replaced with spongy bone in this area. And then eventually, after months and months, that spongy bone is replaced with lamellar bone, and your fracture is healed. And in the end, this final result is usually stronger than the native bone, mainly due to this callus is going to increase the diameter of the bone, and with the increase in diameter, increase in strength. So I like this picture right here. It's a pediatric fracture. Kids heal literally everything, no matter how they look. So here you can see day 1, the fracture. And then by day 7, you can start to see the soft callus forming here, this lucency here. Then by the 2-week mark, you can start to see the hard callus. It's a little bit more thicker appearing because it's starting to fill with that spongy bone. And then by the 6-month mark, you couldn't even tell that there was a fracture there in the first place because it's replaced it with the lamellar bone and it's healed. So then primary bone healing. So primary bone healing occurs whenever compression is generated across the fracture sites. So compared to secondary bone healing, you break, put them in a splint or a cast, and they'll heal with the callus. But primary bone healing is when you end up with compression between it, and it forms these things called cutting cones. So basically what these cutting cones are is areas of osteoclasts coming through, eating away the bone there at the fracture site, and then osteoblasts follow behind them and kind of lay down new bone. And in the center of it is this blood vessel that's here that's able to provide nutrients to the regrowing bone. But if you ever have any gaps in your fixation, the osteoclast can't cross, and then the fracture can't heal. So another important concept is strain. So strain is basically the change in the fracture gap length over the length of the fracture gap. So what this is, say your fracture gap is, 10 millimeters. And with your fixation construct, the fracture moves 5 millimeters. So your strain is going to be 50%. So what you want for the strain kind of determines which type of bone healing occurs. So when you have a strain of 0%, that's when there's no callus induction. You have the primary bone healing occur in the cutting cones. And this happens a lot whenever we want to use compression through compression plating or lag screws. But whenever you have strain less than 10%, only cartilage can tolerate this much strain. So kind of how it happens with the healing, when we're going back to the secondary bone healing, is basically the cartilage comes in and stabilizes the fracture enough below 10% of strain so that woven bone can form. And woven bone can only form whenever the strain is in between 2 and 10%. So when the woven bone comes in, decreases the strain even more. And then when the strain is less than 2%, that is when that lamellar bone can come in and fill the gap. So this is just kind of a summary between primary and secondary bone healing. Kind of what we talked about with the cutting cones, absolute stability, and then no callus formation with direct bone healing. An important thing is that direct bone healing does require anatomic reductions. So basically what that means is if the fracture is broken, you need length alignment and rotation. It needs to be exactly the way it was, because if you put it together not the way it was, it's going to heal wrong and have a lot of problems. So when do we want this? We want this a lot with articular fractures, as well as a lot of simple plane fractures that are able to heal pretty easily with this method. And then with indirect healing, with secondary bone healing, as I mentioned, with the endochondral ossification that occurs, which is the spongy bone laid down and then replaced by a lamellar bone. And this occurs with the relative stability or strain between 2 and 10% and forms a callus. So this is used a lot whenever there are long bone fractures, such as using an intramedullary nail, something like this, just a lot longer. Whenever you have a femur fracture, use it with metaphyseal fractures. And if there's a lot of comminution, there's a million pieces, it's hard to put a million pieces together. So you can bridge it, stabilize it, so then a callus can form and it can heal. And overall, the most important thing is length alignment and rotation, even with secondary bone healing, because it's still going to heal in the position that it is. So if it's twisted, then it's still going to heal wrong. So this kind of leads us into how strain plays into some of our fixation constructs. So down here will be no motion, so absolute stability or strain less than 2%. And we achieve this with compression plating, neutralization plating, buttress plating, tension bands, and lag screws. And we'll go over these here in a second. Here with some motion, as we form the secondary bone healing or relative stability, you do it with these constructs here. But whenever you have excessive motion, there's not going to be any stability, the bone can't heal. And that's when you end up going on to non-union or the bone doesn't heal. So how are fractures fixed? So fracture fixation is a lot of the mixture of biology and mechanics. You want to maximize the biology to the point that the bone can heal by using your mechanics, but say you make a construct too stiff and it doesn't have any strain and it can't heal, then you have a problem. So it's definitely always a mixture of making sure the bone is in the optimal environment to heal, while also making sure that it's stable, but not too stable. So first, I want to go over some of the anatomy of a screw, and you'll all see it here in a second. Basically, the total length of a screw is just from head to tail. And if you're in the OR and somebody asks for a 35 millimeter screw, that's what the total length is. The thread length is the portion of that length that has threads on it. So with this, pretty much the entire portion has threads on it. But if it's like a partially threaded screw, which would only have threads like kind of like this, but the smooth part here, and then threads down here, that would be the thread length. The core diameter is the diameter of the screw that does not include the diameter with the threads. So this will be important whenever we're talking about lag screws later on. The core diameter is what you want on the opposite cortex so that there's room for the threads to grab, versus the thread diameter, which is what you'd want to drill your other cortex that the screw basically just slides through. Thread height is the distance from the core out to the end of the thread. This is really important when we're talking about whether using cancellous screws or cortical screws. Basically, it tells you how much bone can fit underneath that thread and how much of the bone can it grip. And then the pitch is the distance between the screws. This is also important with like cancellous and cortical screws. So the higher the pitch, the higher the distance between the threads. So you can basically fit more bone between the threads. So this lock screw that I have here has a pretty low pitch. The threads are really close together versus that cortical screw. The threads are pretty long apart. So this circle in this here is the thread purchase, and that's what I was talking about. So we have the thread height and the pitch kind of forms a triangle, which is going to be your thread purchase, how much bone it's grabbing. So just going into some more screw biomechanics, the function of the screw is just to take rotational force and turn it into linear movement with the threads that you're using. So how does all of these concepts kind of apply to screw failure? So you have two main failures that can happen with screws. First is a failure in tension, and second is a pull-out failure. So what a failure in tension is basically when a screw breaks, like this here. So one main thing that you can do to prevent this is by increasing your core diameter. The bigger the core diameter, the more strength the screw is going to have. I don't know if y'all have seen cannulated screws. They basically have a hole down the middle. So the strength of those, as we know in geometry, so R to the 4 is what a solid screw like this is for its strength. Versus a cannulated screw, because it's hollow, the strength of that is going to be the radius to the 3rd power. So a cannulated screw is going to have a little bit less tension strength than a solid screw like this. So the pull-out strength basically tells you how easy it is for you to pull out the screw. So if it's gripping really well, you're not going to be able to pull it out. And there are certain things with the screw that you can change to be able to increase your pull-out strength. The first one is to increase the thread diameter. So as I was saying, the more thread that you have out, basically the more bone it can grab, the harder it is going to be to pull out. You can decrease the core diameter at the same time, which then also would help you lead to an increase in thread diameter. Can also decrease the pitch, so you have more threads gripping that cortical bone or the outside of the bone, so that it has a stronger grip on it. So like this is an example of pull-out failure. So that these screws just straight on pull out. There we go. And there's some bone qualities that also affect pull-out strength. So if you have an increased thickness of the cortex, will increase pull-out strength and increase density of the cortex. So this is important whenever you have somebody with osteoporosis, you want to try to maximize your pull-out strength because their density of their cortex and the thickness of their cortex is going to be really low. So that's why whenever you're treating an osteoporotic fracture, you want to use screws that are maximizing these factors right here. So I talked about cortical and cancellous screws. So kind of diving into those further. So the cortical screws, so the cortex is basically the outside of the bone, especially in the diaphysis or the middle part of the bone. Cancellous bone that you use cancellous screws for and present in the metaphysis, or pretty much the ends of the bones in the epiphysis. And there are 3 main differences between these. One is going to be the pitch. So as I was saying, the pitch in a cortical screw is going to be closer together versus pitch in a cancellous screw is going to be farther apart. And you'll be able to see later whenever we get the screws out, there's some cancellous screws over there. If you pull those out and look at them and compare them to the cortical screws, you'll be able to kind of see these differences. It's also the core to outer diameter ratios. So as I was saying, for the cancellous screws, you're going to have more thread height. So your core diameter is going to be lower versus your total outer diameter. So this, because cancellous bone is less dense, how I like to think of it is that basically you're able to fit more stuff. So basically with cancellous bone being less dense and cortical bone being more dense, you want the same amount of stuff here under the threads. So if the bone is less dense, in order to get the same amount of stuff, you want more room here. So that's how changing these factors right here allow you to do that. So as I was mentioning with cannulated screws versus non-cannulated screws, cannulated screws hold down the middle. They like to put precise placement of screws with K-wires. So I have a fracture. We have some K-wires back there that we can also show you all later. But put a K-wire and allows you to directly drill over the K-wire and put the screw over the K-wire in the trajectory that you want. But as I was saying, because they're hollowed out, they have less bending strength. Versus a non-cannulated screw, you don't have this guide with the K-wire, so whatever hole you drill, you have to make it follow that path by knowing what your path was. So if you drill it in one direction, you need to follow that direction, or else you're not going to have another hole in the other cortices to drill through. So locking versus non-locking screws. So this one that I have right here is a locking screw, and it has threads that go all the way up on the head. And let's see, there's some locking plates back there, but basically what this locking screw does is the plates have threads in them as well, and the screw can basically just lock into it. And how does that really help? It helps resist bending and shear, because if you have a non-locking screw, whenever you have an axial load, if these the head with it not being locked into the plate allows the screw to toggle. but we'll cover more with the locking plates later on. The main thing is just to understand kind of the difference in the anatomy of a locking screw versus a conventional screw. So, how can a screw be used for fixation? So one thing that's a really big concept is lag screw fixation. An important thing to know, no one ever asks for a lag screw. They ask for a screw to be used for lagging, pretty much. Because any screw can be used. And the main thing with this is to generate compression, and the compression leads to primary bone healing. Use this a lot with simple fractures. So here's a tibial plateau fracture. And this picture is showing using lag screws in both by technique and by design. So here, by design is a partially threaded screw, and then by technique is the screw down here. We'll go into it a little bit more. The main thing, first lag by technique. The main thing with this is that you want your screw at 90 degrees to your fracture, because if you don't, then you're going to malreduce the fracture. So this is an example of, say you have a 3-5 screw and you drill it with a 2.8 millimeter drill. So if you drill it all the way through with a 2.8 millimeter drill, the threads are going to get the exact same purchase on both cortices. So here and here, and it's not going to cause compression. It's basically just going to be a placement screw. It won't allow this piece to move, but it won't compress here. Versus lag by technique. So this is the AO lag by technique guide. That's really good. So what you do, so say you're using a 3-5 screw. So this cortices right here, you would drill with a 3-5 drill. So what that means, as I mentioned, that's the total diameter. So no threads are going to engage here in this proximal cortex. So then you drill this other cortex with a 2-8 drill. So then the threads will engage in this cortex. So whenever you put your screw in, the threads are not going to engage here. The threads are going to engage here. So then when the head of the screw engages this cortex, these threads are going to keep pulling, and it's going to pull that fracture together. And as we like to say in the OU ortho ORs, got to do the anaconda squeeze every time you do it. And this is lag by design. So lag by design, use a partially threaded screw. So one portion of it, no threads, the other portion threaded. With this, you only have to drill once and place it, but it has some downsides. One, every fracture is going to be different. So the fracture could be here, 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 all these different places, and they can't make 100 different screws with one thread difference. So it does limit when you can use this. Use a partially threaded screw, and say you get it across, this one went all the way across. This area right here would have area that doesn't have threads. So there would be no threads grabbing this area. So then that goes back to kind of the pull-out strength. There's no thread purchase here. So your screw has an increased chance of pulling out. But all these, whether doing it by technique or by design, have their own specific purposes and places to be used. So next, get into how plates are used for fixation. So there are several plate functions. You can use neutralization plate, compression plate, all of these. And a big thing is no one ever asks for a buttress plate. They ask for a specific plate. So this plate right here, you use for a tibial plateau fracture. So they would just call this an anatomic plate, and they would use it for a buttress function. So one big thing to take away is that any plate can be used to achieve pretty much all of these functions in one way or another. So the first thing go over is neutralization plating. So basically neutralization plating, kind of a combination between using a lag screw and using a plate. So how this works is that, so if you place a lag screw is going to help prevent these pieces from moving and provide compression, but it's really not going to have a ton of strength versus bending, rotational, and shear forces. So that's why you put on a plate, and a plate is able to distribute the stress away from the lag screw. So then you're able to get primary bone healing in this area while protecting your screw from failing. And this plate is usually, most of the time, placed 90 degrees to the lag screw. So going to compression plating, compression plating is a really big concept. as I mentioned, allows you to get that primary bone healing. But it's really hard, or at least it was for me because I'm stupid. It's hard to understand at first. So how this usually works is so you'll see on the plates that you'll see over there, they usually have this little ridge. So what you do is you anchor the plate on one side and you screw the other side on one edge of the plate. So basically it acts as a ramp. So whenever this screw goes down, it basically goes on this ramp and down to the place where it'll rest here. Whether that's doing that, it'll pull the plate this way. So if it's anchored on this side, it'll take the piece over here and pull it together and cause compression at the fracture site. And this is what they call eccentric drilling, basically because you're not concentrically drilling, which would be drilling in the center of the hole. You're eccentrically drilling to one side of the plate hole. And this is just kind of an example. You can also use different things to stabilize the fracture. It doesn't always have to be another screw on the other side, but this is kind of just showing you can do it. It's going down. And another important concept is you want to overbend the plate. So there we go. So as you can see, this plate right here, it's flat, it's right up against it. This plate right here is overbent. This is your anchor screw that's going to be here. This is your anchor screw. This is going to be the screw that you're eccentrically drilling. So this is a nice little animation. So this plate with this overbent one and this one flat. So whenever you're placing your eccentric drilling, your eccentric screw, if you don't overbend the plate, basically the plate will compress. But since the plate is basically pulling on this side, it'll cause this far cortex to gap. Versus if you overbend it, whenever it's doing the compressing, it's going to prevent that far cortex from gapping. There we go. Okay, so buttress plating. So buttress plates are used a lot for metaphyseal fractures, specifically a lot of the time in the tibial plateau with pilon fracture. Tibial plateau is the proximal portion of the tibia that makes your knee joint. The pilon fracture is the part that makes your ankle. And basically what these do is they kind of act like these buttresses. They prevent, kind of provide support and prevent this stuff from falling over. So this is an example of a buttress plate. So how this works, so you want to place the plate. So here's the fracture right here. You want to place the plate on the apex of the fracture, which is going to be this area right here. And you want the plate to be under contoured. So whenever you place this first screw here, it's basically going to pull the plate onto the bone because it's under contoured. It'll compress through here and allows for primary bone healing. And then you can also then come up here and place lag screws to the portion up here to provide compression up here. So how this functions is it's going to turn axial loading into compressive forces. So if you have an axial load coming here, it's going to run into the plate and the plate is going to push that fracture piece into the main body of the bone and allow for primary bone healing. So this is another example of using a tubular plate and then placing a lag by design screw up here to compress at the top of the fracture. So axial loading plate prevents the shearing force from going down and turns it into a compressive force across the fracture. So this is just another example from a case that we did the other day. See, there's a lot going on, but so every fracture, it was here. Here's kind of placing that screw at the apex. And if you look closely, you can see a lot more gap here than here after we place that apex screw. The same, taking the under contoured plate and using it to compress, and then placed a bunch of lag screws through the plates. The other thing is the anti-glide plate. It's similar to a buttress plate, but it's primarily used for diaphyseal fractures. And it's used to prevent shearing, similar concept, but it doesn't provide compression like a buttress plate does. So what this is, the anti-glide plate is going to do It's just preventing the fracture from sliding on each other, pretty much. But as I mentioned, it's not going to provide primary bone healing. It's going to provide more secondary bone healing, but in between. Another thing is the tension band fixation. So this is when you place a plate on the tension side of an eccentrically loaded fracture. So most fractures are eccentrically loaded, which basically means force coming through here and there's a fracture. You're going to have a convex side. It's going to open up, and a concave side. So the convex side is your tension side, and that's where you're going to want to put your plate. Because if you put it on the concave side, it's going to have a lot more forces going through it and increased chances of your plate failing. You can also use this with olecranons and patellas. So it's taking a tensile force, and so placing these wires and screws will take that tensile force and turn it into a compressive force at the fracture site. Bridge plating, use this a lot for comminuted long bone fractures. So as I said, there's a lot of comminution. It's impossible to put all those pieces together exactly how they were. So what you do, you usually use lock plating for this. You're able to use lock plating to distribute forces over the fracture. So then it allows the fracture to have optimal strain so that it can heal with secondary bone healing. But as I mentioned earlier, a big thing that you want is you want correct alignment, length, and rotation. Because if you don't, then you're going to end up with malunion, as I was mentioning earlier. And you can use a mix of locking and non-locking screws. For instance, if there was another fracture here, you can always lag that fracture, but then use it as a bridge plate here. So then this is a bridge plating in this area, but it can be a neutralization plate here, or you can lag through the plate. So there's a lot of different things that you can do with one plate. So kind of going back to the lock plating that I was talking about with the lock screws. So with conventional plating, how the plate gets strength is from friction between the plate and the bone, versus lock plating. The plate doesn't have direct contact with the bone, and it gets strength from being a fixed angle construct. So what that means is this, since the screw and the plate aren't connected to each other, as I mentioned, the screw can toggle in the hole. But this, because it's basically one piece, force is distributed over this and is able to distribute and protect the screw from loosening. And you can end up using a mixture of locking and non-locking plates just based on the fracture. For instance, you can, lagging a fracture before locking, or if you have like a really long femur plate, you want to lock screws at the top of it to help kind of increase your fixation strength. This is kind of a animation of the difference between conventional and lock plating. So you can see there, the lock plating locks in, doesn't pull it all to the bone, doesn't pull the plate to the bone, versus conventional plating will pull the plate to the bone, and that's where it gets its strength through that friction. So as I was mentioning, kind of talking about the single beam construct, it's turning axial load into compression, versus whenever you're using a non-locking plate, such as in this example here, axial load can be turned into shear forces. So this is usually how a conventional plate fails, is with load, because it isn't a fixed angle construct, results in the screws toggling, versus with a lock plate, the load is distributed over the plate. The working length, something that's important with lock plating and a lot of different things. The balance between working length and stability, because if you have too much stability and a fracture gap, then your fracture isn't going to heal. But if you don't have enough, then you can end up leading to non-union because it isn't stable. And this is kind of a good example how this has a really small working length, versus this has a lot larger working length. So this, it's really stiff. These pieces aren't able to be close to each other and heal. And there's all the stress is placed on this one single portion of the plate. Versus here, because the working length is longer, the strain is more distributed throughout the plates. Number of screw placements, this is kind of something that y'all can go over later. Basically, going back to working length, the less screws over a long span are going to be better than having a lot of screws in a really short span, as I was talking about. Anatomic plates, just really fast. So this would be sort of an anatomic plate for a proximal tibia fracture, while this is just a standard plate. So they have all their pluses and minuses. There's some anatomic plates we'll use later, but an anatomic plate is good for matching the anatomy. You can end up with a lot of screws on the same level. You can place a lot versus this, you just have one screw for each length of the plate. But they all have their pluses and minuses. Intramedullary nailing, not really going to do anything with that today. Just wanted to have it in here for y'all to look at later. Basically, it allows for secondary bone healing because it's going to be load sharing. So fractures right here, you nail it. Basically, the nail is just going to distribute the force around the fracture. And because you're not compressing at this fracture site, it's going to allow for secondary bone healing. You can ream or place it without reaming. And what reaming does is it basically widens the medullary canal so you can fit a bigger nail down. So the larger the nail, the more stability you're going to have. There's just some stuff on static and dynamic screws. So use a lot of dynamic screws whenever you're treating non-unions. And what that does is it basically allows the nail to move in the segment that's attached to help cause compression at the fracture site and stimulate bone healing. So with this, you can see the round holes and then the oval holes. And basically the oval holes are going to be your dynamic screw holes. And you can use a dynamic screw hole as a static screw. It just depends on where you place the screw. So for this one, for this proximal tip, for this tibial nail in the proximal portion, if you place the screw at the top portion of the dynamic hole, whenever this patient walks, the nail is basically going to move up and cause compression at the fracture site. This is just some more using blocking screws and the bell clapper effect. So after all that talking, this is basically a principle of internal fixation. It's a lot used with orthopedic trauma, which is the basics for all orthopedics. There's a lot of intricacies in orthopedics that you'll feel like you'll never learn. This is just kind of it helps provide a foundation for y'all as you're going and getting more experience with it. And just in general, orthopedic surgery is a very rewarding field with a wide variety of specialties and surgical complexities. So you can do sports and really not have to deal with fractures like this, but the same concepts apply for things that you're doing, whether you're dealing with fractures or whatever you're doing in your field. So there's just some resources in here. There's OTA, educational core curriculum lectures are really good. This is really good basics of fracture fixation video. And then the AO Foundation is really good for this stuff, which is where I got a lot of my pictures from. And it's also good for if you're like prepping for a surgery. They have a lot of technique guides and surgical approaches. So anybody has any questions, you can just email me there. So yeah. Any questions? No. Who wants to play with some bones? Okay. Let's figure something out. Okay. How many rows do we have? How many people do we have? 5, 6, 7, 8, 9, 10. Okay, we have 25 people and 6 stations. So what we can do, we can have basically 4 people at each station, about 5 at one station. So if you're in the back row, move back a row, or yeah, pretty much everybody just shift back a row, because and then just turn around and face the plates there.